Hello, and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. We've got a great episode for you today. Our topic is imaging veterans with toxic exposure. And our guests are Cindy Daniels, a U.S. Army veteran who served in Kuwait, Qatar, and Iraq, and Dr. Greg Mogul, a practicing radiologist and a veteran who served in the U.S. Army Medical Corps. Greg is also Chief Medical Officer of 4D Medical. Cindy and Greg, thanks for being with us today.
Thank you so much for having me. I really appreciate it.
Appreciate the opportunity, Brian. Good to see you again.
Same. So let's start with introductions. Cindy, can you go first and tell us a little bit about yourself?
I'm Cindy Daniels. I'm a veteran. I was in the Army National Guard in Springfield, Missouri. I am a former police officer, a mitigation specialist with the Delaware State Public Defender's Office, and I was the military and veterans advocate for Senator Coons. Currently, I'm starting my doctorate in forensic psychology, and I'm a mom of 4.
Very good. All right. Greg, how about you?
Brian, in addition to practicing radiology and being the chief medical officer for 4D Medical, my background has been both in academic and community-based care, significantly with large integrated health systems. And really, my passion has always been to look at imaging for population health with a lot of experience and passion around lung cancer screening. That's really how I got involved, both personally as a veteran and my interest in those areas. It's come together with this issue of veterans who've had toxic exposures during deployment. And it's really been rewarding to work with Cindy and this entire population.
Thanks, Greg. So this issue of toxic exposure in veterans is what we're going to be focusing on here. And this has really kind of come to the fore recently with some issues like the passage of legislation like the PACT Act, which is what we're going to be focusing on a little bit. Cindy, can you tell us a little bit about your military service and how you were exposed to some of these toxic substances during your service?
Yeah, so I was initially deployed right when the war kicked off. And when
the Persian Gulf War?
This is like Iraq, during Iraqi freedom. Yes. So when I was deployed and we first got over there, I had no idea what a burn pit was. I knew that in our camps, they were burning trash 24/7. I knew that there was black smoke everywhere. I knew that it smelled really bad, but I had no concept of what they were actually doing.
And so these burn pits, these are basically just big pits on the edge of a military camp where they just burn all the trash and substances and nobody really knows what's in there, correct?
Yeah. So what I learned later on was, so Halliburton and KBR had a government contract to build incinerators to burn all of the trash, which would have kept it, from exposing anything to everybody. But instead, they ended up clearing football-sized pits and in the sand, and they were putting everything in there for vehicles, human waste, plastics, all of the things. They were covering it in jet fuel and then burning it 24/7.
Wow. And so you were involved in doing some of this, or are you exposed to it?
So I did it. I knew they were there, but I wasn't actually involved in burning the trash. But I do remember, we were constantly coughing up black stuff and blowing it out of our noses. And we would always make jokes about it. Everyone called it the Iraqi crud. And then we would also be caught in sandstorms. I was a military police officer, so we were constantly out doing missions. And the problem was when the sandstorms came up, they were so fast, we didn't have a chance to the only thing we could do literally was just cover our faces with whatever we could grab. And we were eating it and inhaling it. And so also what I learned later on is the particulate matter in the Middle East is the finest in the world. And so those dust particles we were inhaling, but our bodies weren't able to expel them. So they were just sitting in our lungs.
Now, how long did it take for you to start experiencing symptoms? And what were some of those symptoms that you experienced?
So right before the end of my deployment, I got a really bad respiratory infection. And I remember just being sick for weeks and I was coughing so bad. And the doctors kept trying different treatments, but nothing was working. And that finally kind of resolved itself. And then when I came home, I was having some weird symptoms, like it was everything not even related to respiratory. And so I would go to the doctors and they couldn't find anything. They would run tests and they were like, you're fine. So I'm like, okay, I'm good. And so fast forward, when I became a civilian police officer, I had been a police officer probably almost 4 years. And all of a sudden I was getting out of breath, walking up the stairs, or doing a traffic stop, getting out of my patrol car and walking to another car, which was really strange for me because I was an avid runner. I was in the gym every morning at 5 a.m. And all of a sudden I'm having issues breathing. It was really strange.
And so did you go to seek treatment for what you were experiencing?
I did. So initially I went to a pulmonologist, a civilian pulmonologist, and he ran the PFTs, he did all the tests, and he said he couldn't find anything. So I just kind of continued on, and it kind of got worse. And then at one point, I ended up in the hospital. They thought I had a mild heart attack because my heart rate was spiking and my blood pressure was dropping. And so the cardiologist at the time, he ran, the heart cath and all the tests, and those all came back fine. So he sat me down in his office, and I am so appreciative of him to this day because he said, you know what, I've been doing a lot of reading lately, and I've been reading about these deployment-related conditions. And I really think that's something that you should kind of delve into.
And then what was your next step after that?
So after that, I started reading myself. I'm a researcher by nature. And so I read everything I could find. And so then I read Dr. Miller's study and about the constrictive bronchiolitis. And I was like, this is textbook, like for the symptoms that I have. And so I ended up reaching out to the VA, and I've been really lucky for some of the people I've crossed paths with, because I made an appointment. They had a case manager for the OIF, OEF deployments. And so I made an appointment with her. I walk into her office and I just kind of started rambling about all my symptoms. And she just kept shaking her head. And she's like, you are not alone. This is something, and I'm going to help you.
And so do you feel like you had a positive experience with the VA system?
Off and on, I did. Like I said, I had some really good people, and then I had some really doctors that just ignored me. So I would take all of my research with me every time I went to a doctor trying to find help. I had one neurologist literally push my folder back across the table and said, I just want you to go meditate for 3 months and then come back and see me. And I said to him, no, thank you. I will not be back to see you because there is something physically wrong with me in my breathing. I can't breathe. I had another doctor tell me, they sent me to a doctor at the VA in Philly. He told me, he's like, I have no idea why they sent you to me. I don't believe in this stuff, and there's nothing I can do for you. So it was just this constant, like, doctor after doctor after doctor trying to find the ones that would take me seriously.
But you ultimately did, correct?
I did. So the VA where I was at locally in Wilmington, they agreed that I needed the lung biopsy. And so I had already contacted Dr. Zema at Stony Brook, who was doing research, and I had already contacted Dr. Miller, and they said, as soon as you get your lung biopsy, have them send us the samples, and we will give a second opinion and see if that's what you actually have. So when I told the VA that, the thoracic surgeon said no, that he would not send my samples. And later I found out from another doctor that the head pathologist had said that he too did not believe in any of this. And so there was no way he was sending my samples to anyone. So I stopped, I canceled the biopsy. And I told them, I said, if you guys feel this way, then you don't know what you're looking for, and I don't trust you. And so I want to go see Dr. Zema in Stony Brook because he's the closest to me in New York. And one of his titles is deployment-related respiratory conditions specialist. So that took a huge fight. They denied me at first. I went through Senator Coon's office, and eventually we convinced them and got them to send me to Stony Brook so Dr. Zema could do the biopsy.
And then that came back positive?
It did, and that was kind of was life-changing for me. I remember Dr. Zema still to this day walking in the room and telling me I wasn't crazy and that I had constrictive bronchiolitis and I had all kinds of dust and metal particles embedded in my lung cells.
Oh my gosh. So do you think the issue was that there was just a lack of awareness within some parts of the VA system?
It was, because I remember the same case manager that I initially saw, she reached out to me at one point and she was like, I want you to come. She's like, this sounds really crazy, but I need you to come to the VA and I need you to tell all the doctors about this because they have no idea what's going on. And it was odd because I am not a physician by any means, but for some reason, like I had a better understanding of what was going on because I was living it, you know, than the doctors did in the VA. And there was no consistency across the board. And so you may go to one VA and, you know, they're aware of it, or go to another VA and they had no idea what you're talking about.
Now, so let's transition into the PACT legislation. And so this is legislation that actually created devoted resources to addressing veterans with issues just like you. And this was passed, I think, just a couple years ago. Do you feel like passage of that act has helped? And do you think that awareness within the VA system has started changing regarding some of these respiratory issues that are deployment related?
I do. So the one thing with the PACT Act, it was able to add all of these conditions as presumptives, because when I was first diagnosed, these conditions were not on, you know, the CFRs, the list of compensation things that could be rated. And so it was a long fight for me to be able to get my compensation through, which is another thing that I've seen a lot of veterans struggle with. You know, when I was the military veterans advocate for Senator Coons, I literally had veterans that were on their deathbeds begging to get their benefits through just so they knew that their families were going to be taken care of. And so with this act that's passed, it added all these cancers and all these respiratory conditions as presumptives. The problem is right now, like with constrictive bronchiolitis, it still hasn't been coded. And so when a rater goes to rate it on their list, it still isn't given a code. So it's still stopping some of the compensation claims from going through.
Yeah. Now, you've become involved with 4D Medical, which makes some pretty novel technology for, you know, functional and structural lung imaging. Can you talk a little bit about your experience with that and maybe how it's helped your case?
Yeah, so I was very honored when they contacted me to see if I would participate in the study to have the 4D imaging done. So for me, it's always been, you know, with a normal CT scan, we can see the structure of your lungs. We're still not quite sure what's in there, you know, with everything else, all the other testing. Well, with this, I can actually see and visualize the functioning of my lungs. And I know what's happening in there, it's life-changing for me. It gives me a baseline now moving forward. So if there's, you know, a decline or whatever happens, then we'll be able to see it. And now the most exciting part for me too, is I've been a huge advocate for all of this for other veterans for a long time now. And so I keep saying, I don't want other veterans to have to go through the lung biopsy like I did. It's a horrible surgery. It's painful. And if that's not necessary, then why are we doing it? And so I feel like this is just a simple, no-brainer answer. You know, we have this 4D scan now. They can compare it to us that have had the biopsies, and they can see the same identical things going on. And so they shouldn't have to go through the biopsy.
Yeah. Greg, can you talk a little bit about 4D Medical's technology and how it works? And maybe we'll transition to how it might be of service to veterans.
Yeah, absolutely. Thanks, Ryan. Our company is based around the concept that traditional lung imaging has not kept up in terms of being able to provide radiologists with objective quantitative measurements the way that our partners who do neuroimaging, the way that our partners who do cardiac imaging have come to really rely and provide these objective values about function along with the structural information that we're all used to reporting as radiologists. Lung imaging, other than CT, really hasn't evolved that much, and we're still very much limited outside of nuclear medicine or some experimental procedures like hyperpolarized MRI and others. We're really limited to taking the structural findings and trying to extrapolate what might be wrong with patients' lungs. And it just isn't good enough. And so 4D has been committed since its founding to extracting functional information from traditional anatomic imaging. So we use CT, we use fluoroscopy, we use technologies that are available in every medical center around the world, and simply using post-processing techniques can extract objective information quantifying lung function based on the structural imaging that's been done.
Now, if we were looking at a 4D Medical image, what would we be seeing in there?
So for instance, with our CT-based images, we take a traditional lung chest CT, and if radiologists who are familiar with PET CT, for instance, we look like that in the sense that we overlay a map on the existing structural CT. We add another phase of imaging, just like a PET CT does, where you see the traditional anatomic CT scan, you see the functional PET imaging, and then you see a fusion image where there is overlaid function on structure. And our overlaid function is ventilation function. So right now, we can show where in the lungs ventilation is increased, ventilation is decreased, and importantly, overall, show a pattern of ventilation heterogeneity, which is otherwise not visible. It's not testable. It doesn't show up on pulmonary function tests, traditional pulmonary function tests like spirometry, which all test lung function as a single unit. There is no regional way to evaluate areas of the lungs that have obstructive change or restrictive change. And our technology essentially allows that to happen. What we know now and what we continue to learn, both in specific tissue-based diagnoses and in generalized unexplained dyspnea, what we're learning is that at the root of that often represents changes that don't show up in traditional testing like spirometry and don't show up in the structural tests that we have like high resolution CT. So combining the best structural information, and we do that both with the native CT that you already use. We have a suite of quantitative CT tools that have been around for a long time that also help radiologists quantitate the structure, see how much of the lungs are hyperinflated, see how much of the lungs have increased or decreased density. But then we add the missing piece, which is the function. And with really the best in structure and the best in function, we're putting a whole new set of information in front of the radiologist to be interpreted for the pulmonologist, for the primary care doctor, to help decide which of these patients even functionally has a primary pulmonary disorder. So we see radiologists who interpret a CT and then change the interpretation when we overlay our images. So, and that happens frequently, especially in this population, as Cindy has described. And really that's been, where my personal passion is as a former Army physician and someone who's remained active in veterans issues, is seeing the impact of showing patients exactly what may be wrong with their lungs after having been told for so many years, decades in some cases, that they have no disease.
Yeah. Greg, can you dive a little bit more into this in terms of like what exactly this can show veterans and their caregivers about the damage that was done to their lungs through toxic exposures?
Yes, absolutely. Constrictive bronchiolitis is the term that Cindy used, and it's a term that we still use, but lately the pulmonology community has come together and developed a new term called deployment-related respiratory disease, DRRD. And it likely represents a series or a set of illnesses that are all secondary to toxic exposure, a mix of the toxic exposure from burn pits, as Cindy said, fine particulate matter, and also an increasing knowledge of damage that may have been caused by bariatric pressure, if you will, barometric pressure, blast waves. We know that blast waves cause many kinds of neurological illnesses where there's no penetration. So there seems to be a mix of injuries that the chest undergo in deployed veterans. And I'll say it's not dissimilar to first responders. It's not dissimilar to firefighters, especially wildlands firefighters. And these changes simply happen often in the very, very small airways. And that's where the term constrictive bronchiolitis applies. It affects only the very distal small airways. And it's just not visible on traditional CT.
And so 4D Medical's technology is able to show some of this damage?
That is correct. So fundamentally, our functional imaging takes 10,000 voxels across the lungs and essentially performs a pulmonary function test on every one of them. Instead of a pulmonary function test being performed at the lips, which obviously involves all the lung tissue, all the small airways, all the large airways, and patient participation. So any physician who's either performed or any patient who's had a pulmonary function test performed on them knows that there's tremendous variability in this 170-year-old test. How hard you blow, how hard you breathe in. What we do is we natively demonstrate that same degree of air movement, but at microscopic levels across the lungs. So one part of the lung may be significantly damaged, and another part may be compensating to take care of that, which would produce a normal result. But we actually show the entire map of dysfunction and normal function. And we are elucidating patterns that are very specific to different disease types.
Cindy, you mentioned that you had a lung biopsy to diagnose your case, and that's a pretty invasive procedure. My guess is that there's probably a lot of veterans that are maybe a little concerned about going through that. And could the 4D medical technology replace the need to do a lung biopsy?
Absolutely. I personally know several veterans right now that are terrified of getting the lung biopsy. It's major surgery. It was extremely painful. I ended up in the hospital for 9 days, with my chest tube and all the things. And so they would rather, instead of going through that, they would rather just not fight the VA because it's daunting. But with the 4D medical, technology and imaging, they don't have to go through that. It alleviates that horrible step of everything and shows, yes, you have this, but you don't have to suffer in order to prove it.
Now, this kind of reminds me, Greg, of one of the benefits that's always touted about medical imaging, which is, we don't do exploratory surgery anymore. Yeah. Is your technology something that could replace lung biopsy in cases like this?
Yes. Let me be clear. The development of a definitive non-invasive technology is what we are already researching with the VA. So VA has funded research with us and several of our partners to actually prove at a tissue level that we are a true diagnostic in that sense. I don't want to say that research is complete. All the signs are very positive. What I want to make clear is that the VA secretary has actually recently said that no veteran should undergo a lung biopsy to be diagnosed with DRRD. This creates a catch-22 because there is, as I just said, no definitive non-invasive evaluation method. Ours is the closest. And so we have funded research under the VA to prove that we can be a definitive diagnostic. In the meantime, we can provide a significantly high level of confidence that a patient has disease related to toxic exposure versus disease related to more traditional causes like smoking, and versus patients who may not even have primary pulmonary disease, but might have cardiac disease. So right now, that's why I'm emphasizing the triage aspect of this. Another important point here, Brian, is that even once a patient is diagnosed, it has to be determined what they are entitled to in terms of benefits. Most Americans think that someone who served and is a veteran can get healthcare at a VA. That's not the case. I'm a veteran and I cannot get healthcare at the VA because I don't have a service-connected illness. But even once you do have a service-connected illness, they have to determine how disabled you are. Right now, for deployment-related lung disease, because there is no test that shows it, they go back to traditional exams like pulmonary function tests, which were normal. which is why the patient couldn't get diagnosed in the first place. So we play a very important role in determining how much disability the patient might have on the basis of their illness. These are all the ways in which our technology can continue to serve veterans, can continue, frankly, to serve the Veterans Administration in helping identify the right patients to see.
The good thing about the PACT Act is it's putting all this money towards treatment and care and everything else. And one of the things that we're pushing now, we're trying to work on is a network of providers that, are engaged in this community and engaged in these diseases and everything else that can actually treat our veterans. I do have to go out to the community for my specialty care. And recently I reached out to my pulmonologist and was told that he does not do acute appointments. And so he could not see me until December. And I was having issues. So I myself, I made an appointment and consulted at National Jewish in Denver to see Dr. Rose, who's one of the top doctors in all of this. But I have the ability to do that and I have the knowledge base to do that. But a lot of veterans don't know to do those things. And so that's kind of where we're stuck right now as far as treatment and care.
Yeah. Greg, can you talk a little bit about what 4D Medical is doing to make your LVAS technology available within the VA system and make it more available to veterans?
Yeah, absolutely. I want to be clear. I mean, what Cindy said is important. Cindy underwent an open lung biopsy to confirm her diagnosis before we met. And in fact, she's mentioned Dr. Miller, who performed the seminal study that was published in JAMA that demonstrated that veterans that were evaluated who had normal PFTs and normal CTs that were clinically diagnosed with toxic exposure, but not deemed to be eligible for benefits by the VA. 100 of those patients underwent that biopsy, and I forget the number, but it was well in the 90s or more of those patients had constrictive bronchiolitis. So really, that set the stage, and Cindy participated in a groundbreaking study that showed that among all of the technologies that were available, our technology had the closest correlation with predicting who would have DRRD. So while Cindy herself would only benefit in this case from follow-ups based on treatments that she gets, our focus with the VA right now is the literally millions of patients who have gotten benefits or gotten the opportunity to get benefits under the PACT Act, who really have no second step beyond applying for benefits. There still is no way to get a diagnosis non-invasively. I'm not suggesting that our technology provides you an up and down diagnosis. What we're really interested in working with the VA on is triage and workflows. These veterans now, almost 2 million of whom who have gained access to the VA under PACT, literally have backlogs of months and months and months. And the very nature of this illness, it's very non-specific symptoms of shortness of breath that often develop years after service. There's an acute phase during service, but in many cases, this occurs years after service where other diseases may be coming into play. Patients may also be smokers. Patients may be deconditioned. Our great push, and where we really feel we have the opportunity to add to the VA's workflow here, is to evaluate these FDA-approved non-invasive technologies to at least determine which veterans should go see pulmonologists more quickly, which veterans might have non-pulmonary diseases who might be sent to cardiologists or be taken care of by primary care doctors. We have areas in the country where one pulmonologist is responsible for 80,000 veterans, and it is simply not sustainable. The PACT Act has drawn attention to this, but in the end, there's still only 6 centers of excellence that the VA has that are meant to evaluate people like Cindy. And they can see maybe 5 to 10 patients a month. So, I come from Kaiser Permanente background. I come from the integrated health system, how to make care more efficient and how to get to the right patient to the right doctor. That's really what we're most interested right now in. We have many VA physicians who are interested in putting our technologies in place to help determine triage and assess clinical workflows we can evaluate a patient with CT and predict with a probability that the patient has COPD or a traditional non-toxic exposure, and that patient can follow a certain path. Unfortunately, there are people who have biases about this in every direction. People who say that there's very little deployment-related disease and most of it is COPD or interstitial disease. I'm agnostic on that. What I want radiologists to be able to do is do something practical. And from a practical perspective, these veterans take 10 to 20 years sometimes to see a physician who can tell them that they're unwell, who believes that they're unwell. In the end, those physicians will make decisions about how to treat and how to diagnose. And so what we want to do is help the VA manage those newly present veterans who've come around through the PACT Act, and just how to sort of get them to the right doctor, get them diagnosed, get them benefits, and most importantly, get them cared for the illness they actually have. And that's where we have evidence to prove that there is no better non-invasive way to do this. So that's really our dream right now.
Great. Well, that's a great closing statement, and let's hope that you're successful in helping get veterans access to this technology, because it really is fascinating, and I think it is a big advancement in care. Well, some great discussion today. I'd like to thank Cindy Daniels and Dr. Greg Mogul of 4D Medical for being with us today. Thank you both for being on the show today.
Thank you.
Thanks again, Brian.
All right, signing off for the Imaging Wire, my name is Brian Casey.